live-in-a-box cases. And it's not just going to be me. The whole team is sitting here, so they will be making comments, and you're more than welcome also to make comments. So this is a 68-year-old female patient, rather obese. She's been very symptomatic for the past few months. Has a history of TAVI 70 years ago. She presents with a TE and TT that has massive TR, huge coaptation gap, tethered leaflets. We're going to see all these things in a second. Other history, she has a dual-chamber PPM, chronic AF, Hodgkin's lymphoma with radiation and chemo. And just a small note, a year after TAVI, she had the pacemaker just the day after TAVI, and a year after TAVI, there was some moderate TR. So we have the imaging team if they want to describe what they see.
Yeah, so here is an assessment of the right ventricular function. We see a free wall strain of minus 29%. A dilated right ventricle, the dimension at the base was 57 millimeters, and mid right ventricle was up to 63 millimeters. TAPSE was 22. The fractional area change was about 40%. So reasonably preserved systolic function in a dilated right ventricle. Significantly also dilated right atrium.
And these are...
Yeah, we can see here that we have torrential tricuspid regurgitation. The etiology of it is more likely ventricular functional, and the ERO was estimated at 1.2 square centimeters. Also, we have significant dilated IVC with hepatic vein flow reversal. Biplane imaging from the mid-esophageal view reveals a big coaptation gap at the center of the valve, which was measured at about 15 millimeters. So the patient was ineligible for edge-to-edge repair. Transgastric views show that we have probably 3 leaflets of this valve, or maybe even 4 actually, 2 posterior scallops. The jet is wide from across the coaptation zones. The wire seems to be moving freely in the center to septal posterior area. It doesn't seem to be impinging on the valve.
And these are
Can I ask a question? So this patient had a TAVI before. Left ventricular ejection fraction is good. So this patient had a ventricular functional tricuspid regurgitation. Why?
So as you can see, this is a great image. Maybe from the history, she had a Hodgkin's lymphoma. There was some huge, she underwent radiation and chemotherapy multiple times. And as you said, left side is very well. You get to see this hugely calcified as well from the CT images. So, and you saw the TT and the T image as well. So
right ventricular function is very good also. Very, very suitable case for tricuspid replacement for the large coaptation gap, etc. Should we, for example, measure pulmonary artery pressure, cardiac catheterization in this patient?
So we did have, for the sake of time, we didn't show it. There were raised pressures, right A as well, right atrial pressures, they were high. But right ventricle pressures were more or less okay, as well as the wedge pressure. Okay, so you saw the CT images, very dilated right atrium, right ventricle. You can appreciate the wire as well coming in. As Dr. Chrysoheris said, there's a quadricuspid valve, and you get to see, for these cases, we like to know that the pacemaker has adequate slack, and you'll get to see why when we go to the procedure. This is the current landscape. So heart team approach, we never take decisions, personally, so we discuss them through, and we decided to proceed for a TTVR with the EVOQUE. Dr. Chrysoheris has already discussed about the EVOQUE, so I'm not gonna spend time. That's a very brief video showing about how the company and the people working for the company mount the valve. You get to see the valve right here, and they were going to mount it in the catheter, and you can appreciate the anchors that they will go under the annulus. I'm just going to go very quickly, and you get to see the 28 French delivery sheath, and you see this is the two knobs that the operator uses, the capsule knob and the release knob. This is what you use first to release the valve in the ventricle, and then the blue knob to release the valve in the atrium. And you have a primary, secondary flex, and this is your depth knob. And let me just walk very quickly. And you know how they just mount the valve very quickly. And I'm just gonna go to the next video. So this is how the room is set up. This is the hybrid, GS room, hybrid room. These are the team from Edwards preparing the valve. These are our nurses, operators, imaging, anesthesiology. So you get to see images on the right side as well, radiation and echo initially. So we always pre-close. We're going to use 1 or 2 pre-close depending whether we feel we should go with 1 or 2. There's the Agilis catheter. I'm not sure if Dr. Sparias wants to make any comments.
Yeah, this is the initial part. We have to be sure that we puncture the femoral vein at the right height, not too close to the groin and not too far away, because there'll be a large bore sheath going through. So we don't want to travel a long way under the skin. And then we use the Agilis to take the turn towards the right ventricle and advance the Safari wire alone, bare. And as Dr. Harris said earlier, this is a very important part of the procedure. The Safari wire has to go to the right ventricular apex, avoiding the papillary muscle, and as deep as possible. Otherwise, the capsule won't be able to get deeper into the right ventricle, so the procedure will be impossible. And now this is the step that the only step that the interventional cardiologist us do something. So we advance the device, you see the capsule, and we start giving the primary flex, and then we have to time pulling back the Safari wire and advancing the system, giving flex at the same time. Once this is done and you don't have buckling of the Safari wire into the right atrium, basically the procedure is over for the interventional cardiologist. Very minute movements from now on, and just releasing and retracting the sheath and exposing gradually the valve, initially the hooks and then the rest of the valve. This is the point where we create the initial gap in the capsule, so very tiny retracting of the capsule to create a gap that makes visualization on echo much easier, and this is the point where we define the depth. We have to be, the gap has to be at the coaptation point of the leaflets at this stage, or a little lower, like here. And this is the timeout, and we decide if we have the correct perpendicularities, the correct coaxialities, and the correct depth. If everything is fulfilled, then we proceed to expose the valve. If not, then we have to remove the system out. If the hooks come out of the capsule, then you are committed to deploy the valve. So this is the initial part. We have the hooks to 45 degrees, then to 90 degrees, and then there's the flipping. Now it's completely flipped. And for all of these steps, we do the spinning on NPR, you see on the right side. So in each of these steps, we stop, and we spin the calibers to make sure that the leaflet is moving freely or is engaged into the hooks. And so we do that 9 times. in all these cases, we adjust the depth. So usually, initially, we are a little deeper, 1 to 1.5 centimeters, because when the hooks flip back, then you lose the depth of the system. That's why you need to be deeper at the beginning. If you, at some stage, you think that you are deeper septally or laterally or in the anterior, in the posterior side, you can make corrective movements on the system using the primary, the secondary flex, or torquing the system to obtain coaxiality. And once this is done, then the valve is released. And in all these states, the cone of the capsule, it is retracted at every stage back to be close to the valve. And now we have to remove the cone, making sure that it remains coaxial, so it doesn't, it's not caught on the valve. And now we reverse all the movements on the system, so the primary flex, the secondary flex, and then we close the capsule, and now we can remove the wire, and the procedure is finished. What we're doing is we're using one ProGlide in most of these cases, and a suture of 8 at the end. So basically, it's a very lazy procedure for the interventionalist, but very busy for the echocardiographer.
Excellent. I want to ask a question, especially in, for example, when we use transcatheter aortic valves in tricuspid position, like in valve procedures, we use Lunderquist wire across to the pulmonary artery to make a support. The support for the breast-shaped Safari is adequate, or sometimes do you prefer to put the wire distal to pulmonary artery?
You have to be at the right ventricular apex, because your capsule will have this direction. It will be pointing to the RV apex, so you cannot have a wire into the pulmonary. And then you have to be a wire strong enough, like the Safari, but not so strong to have its own opinion, and gives you a trajectory upwards, anterior. So I think Safari has been tested to have the right properties, to be strong enough, but not too opinionated.
Yes. And now we are...
We're going to move to the second